of Dr. SREEMOL.
Good afternoon. Today I'm going to present topic on ocular manifestations in chronic kidney disease patients attending a tertiary care health center, a cross-sectional study. So, CKD is decreased kidney function or markers of kidney damage or both for at least 3 months. So, either because both, so here both kidneys and eye can be involved, so either because of both organs are the target of the same disease process or because the ocular disease is a result of renal involvement. So, oculorenal disorders. So, this includes the kidney diseases. The manifestation can involve the eye also. So, either it can be malformations, ciliopathies, structural defects, can be metabolic, phacomatoses, vascular. So, these are certain examples in malformations. So, here we can see in Weger syndrome. So, there is Wilms tumor, aniridia in eye. There is involvement of eye. This is aniridia. Then genitourinary abnormalities. In Church syndrome, there is coloboma involving, this is retinal colobomas. There can be renal abnormalities, heart defects. In Alagille syndrome, so there is posterior embryotoxon. In structural, there is Alport syndrome. So this is eye involvement. There is lenticonus, anterior lenticonus. Microchoria in Pearson syndrome. Zellweger disease, there is pigmentary retinopathies. Can be metabolic, that is involved Lowe syndrome. So there is cataract. Cystine crystals in cornea in cystinosis. Cataract in galactosemia. Hemangioblastomas in von Hippel-Lindau disease. In tuberous sclerosis, astrocytomas. There can be either diabetic or hypertensive retinopathy changes. Also, there can be metastatic calcifications, cataract, dry eye, IOP elevation, retinal detachment, or optic neuropathy changes. So, our aim was to assess the ocular status in patients with kidney disease. So, objectives to screen ocular manifestations in patients with CKD and to detect any changes in retina using OCT in patients with CKD. So, this was a cross-sectional, non-interventional, descriptive and hospital-based study involving Department of Ophthalmology and Nephrology in our tertiary care center. So, the sample size was 70 patients with chronic kidney disease. So, the inclusion criteria, patients with chronic kidney disease with a signed, written, informed consent, above 18 years of age, high quality OCT images. Exclusion, reversible renal failure, renal transplant patient, pregnant patients, patients with ocular trauma or surgery. So, we selected 70 patients with chronic kidney disease from our nephrology department and detailed history and examination done. So, these were the results obtained. As we can see, so in lid and nexa, 95% patients were normal with 4.3% showed lid edema. In conjunctiva, 45% were normal, 45% showed pallor, the rest showed pincecula. Lens, normal, 80% were normal, 20% showed cataract lens, cataract changes. Shimmer test showing dry eye in 8% of patients. In case of retinopathy changes, 52% were normal. The rest showed different stages of hypertensive retinopathy changes. 28% patients with there were no diabetic retinopathy changes. The rest showed different stages of diabetic retinopathy. 5.7% showed branch retinal vein occlusion. Only 1.4% showed central retinal vein occlusion. So this was the mean IOP range. IOP right eye where mean range was at the range of 14.29 and left eye 14.13. So this was association CKD and BRVO in patients according to the stages of CKD. This is moderate, severe and end-stage renal disease. And only 1% patient showed CRVO. So discussion. So development of the kidney and retina occur at the same embryonic stage. So both the glomerulus and choroid have extensive vascular network of similar structure. So inner retina and glomerular filtration barrier share similar developmental pathways. The arrangement of retinal pigment epithelium, Bruch membrane, and choroidal capillary endothelium resemble glomerular endothelium, glomerular basement membrane, and podocytes. Also, renin-angiotensin-aldosterone system is found in both the kidney and various ocular tissues that regulate the blood volume and systemic vascular resistance. And diseases involving the type 4 collagen can affect both eyes and kidneys, resulting in retinopathy and nephropathy changes. Also, advanced glycosylation end products cause cross-linking and insolubility of lens proteins, yellowing of the lens, and accumulation of glycation end products in the lens, contributing to its role in the formation of cataract. So diabetes mellitus also affects both the ocular and renal vascular bed. So diabetic retinopathy is characterized by the presence of retinal microangiopathy and ischemia. Arterial hypertension is a significant cause of visual morbidity in patients with chronic renal failure. So conclusion, there is a substantial evidence of a close association between eye and kidney disease. The involvement of the eye in renal disease can be either because both the organs are the targets of the same disease process or because the ocular disease is a result of renal involvement. So recognition of overlapping pathophysiology between the renal and ocular disease helps in prompt diagnosis and treatment of patients with potential ocular and systemic morbidity. So these are my references.
Findings are normally seen, any chronic problem along with the diabetes. You can see the fundus findings and all. Complications are almost same. See, the findings you are told, they are not new. They've been accepted for so many years. But I want to know that you are told about Lowy syndrome and all. You mentioned, no, Lowy syndrome.
Love syndrome. Yes, sir.
Love syndrome or whatever syndrome. You mentioned, no?
Yeah, mentioned.
Do you know something about that syndrome?
Oculocerebral renal syndrome.
Very good.
In ocular, there is.
You are appearing for exams.
Next year.
Next year, then okay, we can ask questions. No problem.
There can be cataract.
You tell me, what type of inheritance is this? Autosomal? Huh?
Mitochondrial.
Okay, I will tell you one thing. You are having Lowy syndrome. Is it correct or not? I'm telling you now, you are having Lowy syndrome. No, how do you know? You must tell, sir, it's an X-linked recessive problem. I'm a girl. I'm only a carrier. Later you must tell in exams. Are you to follow? One more thing, beauty of the Lowy is what? Both congenital cataract and congenital glaucoma may be coexisting the same patient. That's what the peculiar feature of that. I don't want to ask about the enzymes and all. They will confuse so much confusions.
Most important clinical thing what you think about CKD and IUS, you think about all patients with CKD, they do have some amount of anemia, right? They can have optic neuropathy. So unexplained vision loss or dyspallor with no significant vision loss, always rule out anemia in these patients. So you need to intervene accordingly. Okay, so temporal pallor, but the vision is good, always rule out anemia in these patients. This is what you should learn. Any patient CKD, systemically evaluate them completely. Most common manifestation I use is optic neuropathy only.
Certain disease pairs are vicious cycles. One disease affects the other affects the same. CKD and diabetic retinopathy are vicious cycles. As diabetic retinopathy evolves, secondary hypertension comes and complicates it. Uremia complicates it. Anemia complicates it. When I heard this topic, I thought you'll delve into those things. Those are the key factors which are affecting day-to-day practice in ophthalmology setups here. Low E disease will be, of course, yes, but very rare. Trying to associate all the congenital anomalies and systemic anomalies with the CKD. CKD is a burning disease. It's not a dormant disease. So when you think CKD, then you think emergencies, you think crisis, you think issues where electrolyte imbalance comes and complicates a macular edema. That is what you should think about. Okay. So restructure your thing and think in those lines.
Thank you, Dr. SREEMOL.